Thank you to everybody who has joined today. It's great that you've been able to make it, and I hope you'll find it a really useful session. My name's Jo, I'm the Charity Secretary for PoTS UK, and I'm really thrilled to welcome Dr. William Whitehouse. We're all very grateful for you giving up your time today, and I think it'll be a really popular session that hopefully will help a lot of people. Dr. Whitehouse is the Honorary Clinical Associate Professor for the School of Medicine at Nottingham University and a paediatric neurologist. So the plan will be, Dr. Whitehouse has got slides that will last for about 30 minutes. If throughout the session there's anything that you hear that you think, I don't actually understand that, feel free to quickly pop your question in the chat box and we'll try and answer those live, if it's just to clear up a point that's being raised. If it's something unrelated but just something you want to know the answer to, if you pop those in the Q&A box and we'll address those at the end, because it could well be that Dr. Whitehouse will answer those throughout the session. So if that's okay, that would be great. It will be recorded, so if anybody's on a lunch break and can't stay for the whole session, it will be added to our YouTube channel within the next couple of days. And we'll put a note on our social media platform so that you're aware when it's up on the YouTube channel. And I think that's everything. Yeah, feel free to ask your questions. We'll try and cover as many of them as possible. If we can't, then we will try and arrange to answer these afterwards in some sort of way, but hopefully we'll get through them all. But yeah, thanks everybody for joining, and over to you, Dr. Whitehouse.
Great, thanks, Jo. I'll just try and share the screen now. And thanks for giving me the opportunity to do this talk. So there'll be people listening who will know a lot about PoTS, but I've pitched this at a level of people who are interested but maybe don't know that much about the basic physiology around blood pressure and heart rate control, and also pitched it to try and help a bit with terminology and understanding where that comes from. So I'm sorry, some of it, perhaps most of it, is going to be a bit basic for people, but I'll be here to answer questions at the end. I hope maybe some young people can follow it as well. Okay, so orthostatic intolerance to young people. This is what I did last time, isn't it? Okay. Just trying to advance the first slide. Okay, so I'll cover orthostatic hypotension, postural tachycardia syndrome, and a little bit at the end on functional orthostatic intolerance and intracranial hypotension. Okay, so what does that mean, orthostatic intolerance? So ortho means straight, right, or proper, like an orthopedic surgeon is there to try and straighten children whose bones get curved. As static means stable, stationary, motionless. But in this context, orthostatic means on standing upright or standing up. And intolerance just means development of adverse effects or symptoms. So orthostatic intolerance is development of symptoms, adverse symptoms on standing up or being standing up. Orthostatic hypotension then is the first thing I wanted to talk about, but because the physiology underpinning this does relate to PoTS in a roundabout kind of way, we'll come on to. So hypo generally means low, under, down, below normal. So most people are aware of the term hypo referring to people who have a low blood sugar or hypoglycemia, for example. And tension generally means stretched tight or stress or pressure. And in this context, hypotension normally applies to blood pressure being abnormally low or unhealthily low. So hypotension. Blood pressure is traditionally measured in quite an arcane unit of pressure management, not like your car tires, in millimeters of mercury. Car tires used to be measured, still think they are sometimes, in pounds per square inch, and that's quite a nice way to think about it, as the pushing on an area like a square inch, so how much weight is being pushed on a small surface area. So the blood pressure is the pressure of the circulating blood against the blood vessel walls, and we usually take it in the large or middle-sized arteries. And it's important to have enough blood pressure to push the circulation round the body to get to all the organs. So this is a little cartoon of the circulation there on your left-hand side, of the arterial blood in red and the venous blood in blue, going round in a little girl. They've got skeleton on the right-hand side. And although it's been known for probably several thousand years that veins and arteries were different, so the color of the blood was different and their structure was different, it wasn't really until 1630s that the idea that it circulated and that the veins and arteries joined up became popular. And that's William Harvey who did those experiments hundreds of years ago to demonstrate the circulation of the blood. And the key to that was that there are these capillaries which join up the arterial in red there and venous in blue, their system. So they're microscopic, and the capillaries are just big enough to let a red blood cell, which is microscopic, squeeze through, and they enable red blood cells to get very close to the cells of the tissue, either muscle or liver or brain or whatever it is that is being perfused, is having the blood flowing to it to give up the oxygen from the arterial side and to pick up carbon dioxide and waste products from the cells and push them out into the venous side, which goes to the lungs to get rid of carbon dioxide and pick up more oxygen and go round and round. You can see in that little cartoon of the capillary bed that there are some smooth muscles, particularly on the arterial side, but there are also some smooth muscles on the veins there, although they're not so much. So that means that the arteries near the capillary beds can constrict and dilate, and so can the veins. And we'll come on to the importance of that later. So this is a bit of a complicated diagram, which I have used for medical students. It's from a nice little textbook of physiology. So if we look at the top of the diagram, we've got the arterial side here in the light brown and the venous side in blue here. In the middle is the heart with two chambers. So the heart pumps venous blood that returns from the body out here through the lungs, comes back into the heart on the left side, and it's pumped around the whole body here in the arteries. So these are the blood supply to the head, to the arms. This is the lungs blood supply. This is the blood supply to the heart muscle itself, the coronary circulation. And then we've got blood supply to the liver and the gut here, blood supply to the lower limbs and the pelvis down here. And most of the blood at any given time is in the venous system. And if you have a lot of tension in the arteries and veins, you can divert blood to different places. So, for instance, if you are frightened or you're going to have to fight or run away from danger, and your heart rate speeds up, your pupils get dilated, you start sweating, and you look pale because the blood's diverted away from the skin to the muscles to help the muscles work harder. If you're digesting a heavy meal and you're feeling a bit sleepy, then the blood's diverted away from your muscles and to the guts and to the bowels here to help you digest the heavy meal. So it's a bit of a variable dynamic system, and the size of those veins and arteries can vary, and that's controlled to the autonomic nervous system, which I'll come on to in a minute. So measuring blood pressure. So this is the classic way of doing it with a cuff. You probably all had this done. It's blown up, and this is a cross section showing that the cuff is squeezing the artery, this case is the brachial artery in the arm, and then it's letting go. So it squeezes up till the blood supply is squished out completely, so there's no blood flowing through the artery. That's why it hurts a little bit. And then it's gradually let off. And as soon as the blood starts to pulse through, that's the pressure called the systolic pressure. And then when the blood flows freely, that's the diastolic pressure. You've got those two numbers, and I'll explain that a bit more in a minute. I'm explaining a lot in a minute, aren't I? So these are various devices for measuring blood pressure. When I was a medical student, we used these kind of sphygmomanometers and a stethoscope to listen to the pulsing sound of the blood when it started to come through. That was the systolic blood pressure, and when it sort of went muffled was the diastolic blood pressure. Mercury ones aren't used anymore because mercury is poisonous. This is an aneroid one, which gives you a little dial, and you can see the beating of the dial, and as well as you can listen. Generally nowadays we use these kind of machines in hospital, a digital machine, and some of you will have your own blood pressure monitors at home, either on the brachial artery or the radial artery here. And some of you may even have come across these wristbands or bracelet devices that measure blood pressure. They have to be calibrated against the blood pressure cuff, but I don't have personal experience of them, but I suspect they're quite good at measuring blood pressure. It uses optical technology to pick up the pulse in an artery such as radial artery, and the shape of that pulse waveform is translated into blood pressure measurements by the computer in the little device that comes with it, like an iPad, no, not an iPad, like an iPhone that comes with it. So this is the shape of the pulse. So this blue time is along here, okay, so along the horizontal line at the bottom. And then if you look at this blue line is the pressure in the ventricles, the pumping chambers of the heart. So this is the electrical signal that tells the heart muscle to contract, the ECG. And at this point, the pressure goes way up, okay? And then it comes down. So that's the heart sounds are lub-dub, then a pause, lub-dub. So this bit here between the lub-dub of the beating heart is systole. That's when the heart's pumping. And this is when the blood is being pushed out. And then in between the heartbeats, in that gap, the veins bring blood back into the heart, into the right side of the heart, and from the lungs into the left side of the heart. Sorry, into the right side of the heart from the body, yeah. So there's a heartbeat. And then this line here is the pressure wave in the aorta, the big artery out from the heart. So it's got this kind of shape, okay? And it's from that shape in the arteries in the wrist that those optical devices kind of work out what the blood pressure is, as long as you calibrate it against the cuff once a month or so. Heart sounds are made here, the first heart sound, the mitral valve closing, that's this valve here, as it starts to push blood out, or this valve here, sorry, as it starts to push blood out up the aorta. And the second heart sound, the dub bit of the lub-dub is the aortic valve and the pulmonary valve closing, which are these valves here. And this is the shape of the pulse waves you get in different arteries. So this is, in this diagram, we've got the pressure wave looking like this in the start of the aorta. And then in the arm, it looks like this. And in the wrist, it looks like this. And in the fingers, arteries in the finger, it looks like this. Some of you may have had head-up tilt tests with beat-to-beat blood pressure monitoring, and they generally or often use a blood pressure in the fingers like this to get every single heartbeat's blood pressure recorded. So hypotension means that the blood pressure, so the mean blood pressure, or either the systolic or diastolic, is too low to perfuse the organs of the body properly. And the most, from my point of view as a pediatric neurologist, the brain's the most important of those organs. And so if it's not perfused enough with blood, then the function of that organ, so the brain function, will be impaired and you can lose consciousness. So those of you that have had a faint or syncope may have had pre-syncope. These are symptoms before loss of consciousness, when the perfusion of the brain isn't enough for the brain to work normally, but isn't bad enough that you go completely switched off. And common symptoms in that include change in your vision. So you might see pixelated vision, like when the TV's on the blink, or you might see a graying out of the vision or a loss of vision completely, or you might see that things look close up or look far away, which are kind of difficult perceptions to describe. And you can also get changes in hearing, such as the hearing sounding like it's underwater, so a loss of the high frequency sound, or the hearing sounding as if things are very close to you or far away. So changes in vision and hearing are very indicative of symptoms that the brain perfusion's impaired and may be about to switch off completely. So the brain may be about to switch off completely, or maybe loss of consciousness going to happen in a few seconds. So transient hypotension can give rise to transient loss of consciousness, or TLOC. And in this situation, when you get transient loss of consciousness due to hypotension or drop in the perfusion of the brain, that's called syncope, which you'll have heard of, I'm sure. So this is what happens to your brain during syncope. This is a 11-year-old boy who's on a tilt table test, and we've got time along here, along the bottom again. You can just see these lines here, the ECG. So each of these lines is a heartbeat, and you can see on this page they're beating along pretty regularly, normally. And all these wavy lines are the brainwave activity. And here, that's the normal kind of pattern you pick up from an ECG when it's placed on the scalp. What happens here is the movement artifact, that's that darker bit and wavy bit, and the heart rate's still beating along okay. It's slowed down a bit. And then here, there's a stop in the heartbeat. So the heartbeat stops completely here. And you can see there's normal EEG activity, normal brainwave activity for about 5 or 6 seconds. To each panel is about 10 seconds. And then you start to get some movement and also slow waves here. So these slow waves in the brainwave EEG, slow waves on the EEG, are what you get when you're in deep slow wave sleep. Also what you get if you're got flu and are feeling really sleepy and can't concentrate, indicative that the brain's really slowing down, not working properly for being awake anyway. And then what happens after about 10 seconds of no heartbeat, the brainwaves go completely flat. So at this point, the boy was completely unconscious, deeply unconscious, and went stiff. And that lasted till about here. After that was about 18 seconds. And then at this point on panel panel E, near the end of panel E, the heart starts beating again spontaneously. So that was a transient drop in blood pressure because the heart stopped beating for 18 seconds or so. And then you've got these slow waves of being sleepy again after, but the child recovers then. So that's a type of vasovagal syncope, where it's predominantly caused by a stoppage of the heart from beating because of massive vagal discharge. That's the nerve that tends to slow down the heart, triggered by the head-up tilt test, but can be triggered in life by surprises and shock and pain and things like that. So, okay, I think, yes, I've shown you two there, that one, and then this other one. They're two different children, 2 different ages, but you can see they're very, very similar. So how do you keep an adequate blood pressure? So the blood pressure's there to keep the brain perfused and the other organs perfused, to keep them perfused with oxygen. So if you don't have enough oxygen being carried around in your blood, you'll likely have inadequate blood pressure, even when the blood pressure would have been all right if you had a good amount of oxygen carrying. So anemia, which means low hemoglobin, which is the molecule in red cells that carries oxygen, tends to make you more readily faint than if you're not anemic. That makes sense? Likewise, the blood carries glucose or other fuel around the body. So if you're hypoglycemic, you're more likely to faint as well. And hypoglycemia, if severe, can cause a loss of consciousness because you're not giving energy to the cells, particularly the brain, which therefore switches off. And you need to maintain your blood volume. So obviously, if you have an accident and you're bleeding a lot, you can go unconscious. Or if you have an allergic reaction, your blood vessels dilate and become leaky, and your blood volume can drop because of the salt water in your blood leaking out from the blood vessels themselves. So you've got to maintain those, but also maintain the pumping of the heart, maintain the squeeze of the blood vessels. The tone in the blood vessels can't get too floppy and loose, otherwise the blood pressure will drop and you won't be able to perfuse the brain and other organs. And maintain the blood vessel integrity, like I just mentioned, about avoid leaks in your blood vessels. And those control the pumping, and the vessel tone is controlled by the autonomic nervous system, which I mentioned earlier. And here's another complicated diagram from the medical student book, I'm afraid. If we look on the right-hand side first, you can see what happens to manage your blood pressure control long-term. So your body can pick up when your blood pressure is too low and then secrete hormones, particularly one called ADH, which antidiuretic hormone tends to make you pass less urine, so hold on to water, and another hormone called aldosterone, which again holds on to salt in your kidneys, and because your kidneys are holding on to more salt, they'll hold on to more water as well. So that increases the blood volume, ADH and aldosterone. And then on the panel A, we've got what happens from second to second, minute to minute, hour to hour, controlled by the autonomic nervous system. If your blood pressure drops, that's picked up by these baroreceptors, and your arteries constrict a bit, increasing the tension, the squeeze of your arteries around the body to push up the pressure, just like squeezing a balloon pushes up the pressure in the balloon. Your heart rate will increase, and the force of contraction of your heart rate will increase, and your veins will also increase their tone, and that all goes to increase the blood returning to the heart and increase cardiac output and restores the blood pressure. So increasing the heart rate will help restore the blood pressure, but it's not as effective as increasing the tone in the veins, for instance, for bringing more blood back into the heart. Okay, and that's just a diagram of the autonomic nervous system. I think we'll skip over that for this point. So wanted to thank Ward and Linden for those nice pictures from their physiology textbook. So as well as the heart pump, this is the calf muscle pump. And what happens here is, with contracting your calf muscles, you squish the veins which run through the calf muscles. And because there are valves in it, the blood doesn't go back too far down the way, but it does go forwards up the way, and then it's held by a valve here. And then when the calf muscles relax, more blood can flow up, but it's not flowing back down the way because the valve holds it here, and then it squishes again. And so squishing the calf muscles, pumping the calf muscles, will actually pump venous blood back into the heart, which then increases venous return, increases cardiac output. Okay, so what are the thresholds for blood pressure? So there's some been agreed internationally. This is mainly based on adults, but it applies okay to teenagers. I don't know what we can do about children, primary school children, though, because we don't have good data for defining what's hypotension in younger children. We've got normal ranges, but mostly people have been looking at high blood pressure because that's more life-threatening than low blood pressure. So orthostatic hypotension in adults and teenagers, we take as either a fall in blood pressure, a systolic of 20 or more, or a fall in diastolic of 10 or more. And this is on standing up or standing up for a long time. The other abnormal numbers that are useful in this context is what comprises postural tachycardia. So in teenagers, it's been decided that a rise in heart rate of 40 beats per minute or more just on standing up and just due to standing up is abnormal. So that's postural tachycardia. In adults, it's traditionally been 30 beats per minute. So people 20 years and older generally take it as 30 beats per minute or more. Obviously, on your 20th birthday, there isn't a sudden change in your physiology. So these numbers are really guidance rather than absolute physiologically definite. So some people would be all right with a heart rate rise of 40 beats per more, and some people would have symptoms if it was less than that, or at least sometimes it was less than that. So that's postural tachycardia, and PoTS would be caused by that and would be demonstrated by us being able to measure or document such a high rise, plus a whole load of symptoms that are disabling that go along with it. So I have seen some teenagers who've had an excessive rise in heart rate like that, but who were symptom-free, so they don't have PoTS. And just as I've seen some children who have a drop in blood pressure like that, but with no symptoms either. So the numbers are average general numbers, rule of thumb numbers. And for individuals, there might be individual numbers that are more telling, but of course, we don't know that for sure or what the numbers would be for an individual. So orthostatic hypotension is often associated with orthostatic intolerance. So that would be getting symptoms from it. And especially the pre-syncope symptoms at the time of the standing up. So then I mentioned the visual symptoms and the hearing symptoms, but also you can feel hot and sweaty and sick and dizzy and faint, and that kind of woozy feeling that's hard to describe with it. And some people get headache with it. It's often associated with loss of consciousness. So when you lose consciousness with your blood pressure dropping when you stand up, that's a type of vasovagal syncope. So where your autonomic nervous system controlling your heart rate, force of contraction, and the tightness of your blood vessels doesn't respond adequately to the challenge of going from lying down to standing up. And normally when you go from lying down to stand up, your heart rate will go up a bit and your blood pressure will go up a bit. In orthostatic hypotension, it goes down. So your blood pressure goes down. Okay, so orthostatic hypotension associated with fainting or transient loss of consciousness is often misdiagnosed as PoTS because the symptoms are the same, or a lot of the symptoms overlap. And actually the management is very similar to the kind of first line management in postural tachycardia syndrome of trying to increase the blood volume and blood pressure. Obviously, we don't want the blood pressure to go too high, otherwise that would be dangerous. So you have to watch out for that. Now in PoTS, it's often associated with orthostatic intolerance, including those pre-syncopal symptoms, but also palpitations where the person feels their heart beating very fast and strongly, and that can be quite frightening. And fear and anxiety just make that worse, because that's an unconscious response to fear, is putting up the heart rate, as I mentioned before, that pupils dilate, going pale. So that just makes it worse. So the more you understand, or the person understands about what's happening to your body, the less frightening it can be, and the easier it is to get through the symptoms and not let them incapacitate you. With disabling symptoms in between, so that's not usually the case with orthostatic hypertension, but patients with PoTS will have disabling symptoms in between actually standing up, and maybe so severe that they can't even sit up, let alone stand up. Other symptoms that are key to PoTS would be chronic fatigue, chronic pain, brain fog, and lots of other symptoms. It's less often associated with syncope or transient loss of consciousness, which is a clue, really. And I think this adaptive model is a nice way of thinking about PoTS, at least in some patients with PoTS. It's the autonomic nervous system trying to prevent the person from losing consciousness. But it's relying excessively and for too long, chronically, on just increasing the heart rate, rather than what would be less fatiguing, rather than increasing the blood volume, for instance, or increasing the blood vessel tone, increasing the tightness of the arteries and veins. So some people's physiology, autonomic nervous system, will just focus on pushing up the heart rate in an attempt to stop the blood pressure dropping, which is not efficient and doesn't work out very well, and there's a big cost in terms of fatigue and the other symptoms. So with the management, so on this slide, we've got things that are in common between PoTS and orthostatic hypertension in terms of management. So inform, explain, empower, reassure, point people in the way of the support groups like PoTS UK, and particularly if people are having syncope, then STARS is useful information source. Gauge the disability, which can be a challenge sometimes. And I think the first thing to mention is these maneuvers. So these are sometimes called counter pressure maneuvers. So there's squatting down, there's standing with feet crossed, legs squeezed tightly together, arms folded. So all those increase the skeletal muscle tone, which tends to squeeze the vessels and tends to increase venous return, and can stop you going unconscious if you're going unconscious, and might help with the symptoms of PoTS when you're getting standing up. And drinking a large glass of water will help as well. That increases the blood pressure temporarily. The stretching of your stomach when you drink a large glass of water, it feels kind of like a brick you swallow, doesn't it, when you drink a large glass of water, gulp it down quickly. You feel a heavy feeling in your stomach, and that stretch of your stomach will actually cause a reflex to increase your blood pressure. So that sometimes helps, certainly with syncope. Increasing blood volume, so avoid dehydration, drink plenty of water, avoid things that vasodilate. Vasodilation is the relaxation of the arteries and veins and blood vessels. So avoid alcohol, caffeine, smoking, they're all strong vasodilators. Take enough salt, so you can use slow sodium supplements for that. Quite rightly, the government and most doctors will counsel everybody against having a high salt diet. High salt diet is generally unhealthy because it puts up your blood pressure a bit, and you can end up with a high blood pressure. So what we want here is to take enough salt, but to keep your blood pressure in the normal range, but give it a bit more reserve, so that if it drops a bit, it's not going to make you feel so ill or cause a syncope, for instance. Now, sometimes the salt doesn't work because the kidney just wheeze out all the extra salt you eat. So if drinking plenty of water, taking salt doesn't work, then it's worth adding in fludrocortisone. That's a synthetic hormone like aldosterone, which tells your kidney to hang on to more salt and water. So that'll help to increase blood volume, pushes the blood pressure up a little bit, but we need to watch that doesn't go too high. Another strategy is to increase blood vessel tone. We mentioned that quite a bit. You can help do that by increasing your muscle tone generally through exercise. You can wear compression stockings, especially the tight ones that come up to your tummy button, so they compress the tummy, the abdomen and the pelvis as well as the legs, most effective ones, but they're not always tolerable and always comfortable. But I've certainly seen some teenagers with PoTS do really well with compression stockings. And midodrine is another drug that tends to squeeze the smooth muscles around the arteries and veins, so that increases the tension there and stops the blood pressure from dropping too low, which will help. So this diagram of the counter maneuvers in a man, so it's published by the Dutch group, Walter Wilding, and I think he had a patient who found these out more or less himself, who had a neuropathy of the autonomic nerves, so didn't have PoTS or orthostatic hypertension, but did have that neuropathy does cause severe orthostatic hypertension actually, and he found these helped. And then this also works for people who don't have neuropathies in their nerves, but just have reflex or the common or garden orthostatic hypertension. And here are some things to think about for PoTS in addition to the things I mentioned on the previous slide. So try and mobilize support for the other symptoms, particularly chronic fatigue, disabling symptoms, including pain. Try and support social participation, education, and mental health. So that's more easily said than done in the current NHS. Unfortunately, it's difficult to access the support people need. Limit excessive tachycardia. So that can be done with a low dose propranolol. High dose propranolol tends to make things worse, or ivabradine, which again tends to stop the heart from beating far too fast. And I think review the diagnosis. So Joe, were there any questions there so far on the chat?
The only one that popped up so far was how does salt help? But then I think you went on to cover it.
Okay,
so
yeah.
I think that was everything so far.
Yeah.
People do, definitely feel free to pop questions into the Q&A box so that we can go through those.
Okay. So I'm aware I've kind of rushed through the PoTS symptoms and focused more on the physiology and some quite basic stuff, but I hope that's been helpful. I was just going to say a little thing about functional orthostatic intolerance. So this is rare. This would be orthostatic intolerance, or the symptoms on standing up with normal blood pressure and heart rate physiology. So I've seen this in young people who've had a history of vasovagal syncope or orthostatic hypertension previously, but it can happen to those people even when their heart rate and blood pressure is normal. And it's sometimes associated with other functional neurological symptoms and signs. I think the important thing here is it is coming from the brain. It's subconscious, it's automatic thing that your brain's doing, and it's not pretending, it's not a deliberate thing. And it's more, these kind of illnesses, functional disorders are more common than are generally recognized by doctors or are talked about by doctors, because I don't think we have a good vocabulary to describe it, but that's improving. And John Stone is an adult neurologist, has done some very good work in explaining about functional neurological symptoms and signs. And I won't talk more about that at the moment, just to say that they often happen alongside physiological abnormalities as well at other times in the same people. So again, we'd aim to improve participation and confidence. And sometimes multidisciplinary rehab is needed for those kind of problems. And then lastly, this low intracranial pressure. So that's very rare and difficult to diagnose, but can cause orthostatic intolerance with symptoms, particularly headache and dizziness and feeling really lousy when you go from lying down to standing up. And I think the model for this is, some of you may have had a lumbar puncture actually, and have come across a post-lumbar puncture headache or post-lumbar puncture symptoms. So what happens with a lumbar puncture, needle goes in to the back and punctures the dura, which is the tough lining around your brain and spinal cord, and samples the CSF, which is the fluid the brain floats on in the head. And sometimes after lumbar puncture, there's a leak of CSF from that hole that it's made. And that can last, usually it just lasts hours or a few days, but sometimes it can last much longer. And so although your brain makes lots of CSF every day, in fact, quite a lot every hour, if it's leaking more quickly than it's being made, then you'll have low pressure inside your skull. Your brain will slump down and it's quite heavy and it's not able to float anymore, and it's dragging all those nerves and dragging the sensory nerves in the dura, and can make you feel really lousy. So that can happen after lumbar punctures. It can happen after trauma, so maybe in a motor vehicle accident or car crash or something like that. It can happen after having too high intracranial pressure. So that's IIH, stands for idiopathic intracranial hypertension. It can happen after that. If you've had very high intracranial pressure, that can cause a leak by puncturing somewhere along the line on a weak spot, the dura. It can happen after neurosurgery, and can happen after spinal surgery. Sometimes it happens spontaneously. It's difficult to diagnose. The best way is through MRI studies, are quite helpful. And there are several clues on MRI, and then neurosurgeons can measure your intracranial pressure if it looks likely over a couple of days, and see that it's quite often negative or too low. It can be treated with surgery if you can identify where the leak is coming from, or sometimes a blood patch is inserted into the using a lumbar puncture needle, a patch of your own blood squirted in so that it clots and makes a little seal on the leak. Quite difficult condition to treat and diagnose. So I've covered orthostatic hypotension, a bit about postural tachycardia syndrome and how that is, I see it as a way, at least in some patients, that your autonomic nervous system tries to avoid the blood pressure dropping. A little bit on functional orthostatic intolerance and intracranial hypotension. So if there are any other questions now, Joe? Sorry, I've gone on a bit.
No, not at all. I've had a couple of lots of people message in to say thank you very much, wonderful explanation, and they're looking forward to rewatching it with their children and their teens. So thank you very much indeed, really informative. And I sometimes think, I mean, listening to it wouldn't be basics for most people, because that's a huge amount of information, but I think it is so good to kind of go back to the beginning and really explain it, because it's a great place to start. So thank you so much. We've had quite a few questions come in, so I'll start going through them. So does orthostatic hypertension affect heart rate like PoTS does, or does it just relate to blood pressure?
Yeah, no, nice question. So orthostatic hypertension is just describing what's happening to the blood pressure. So during your symptoms with orthostatic hypertension, your heart rate will rise because it's trying to stop the blood pressure going down. So by convention, certainly the European cardiological societies have agreed that if you get both drop in a blood pressure too far, so more than 20 systolic, 10 diastolic, and you get a too high rise in heart rate, then that's called orthostatic hypotension. So they've just arbitrarily said it's not both at the same time. So it's like the orthostatic hypotension trumps the tachycardia. But what's interesting with PoTS is that generally you don't get a drop in blood pressure. So it's actually doing its job, but at a cost to your heart rate and a cost to you in terms of those symptoms for having such a high heart rate for so long.
Brilliant, thank you. I've got another one. My daughter has spikes and fast drops in blood sugars as well as syncope about once a week and brain fog. She struggles to stand up in the morning until she has sat up in bed for a while and had lots of drinks. Can these symptoms all be the same disorder? She is eating every 2 hours, drinking lots, but at the age of 13, she's still struggling.
Yeah, so it sounds like PoTS from that. I wonder how low the blood sugar goes. Is that measured, or is that just the feeling? Is that just a feeling of low blood sugar, or is that actually a measured blood sugar?
I don't know if you want to, the person who asked that question, I don't know if you want to pop the response in the chat, but it's not in the question, whether it's measured or not.
You know, it does sound like PoTS, and yeah, it's very disabling.
Okay, thank you. I'm trying to pick ones that will help most people. You said that some people experience disabling symptoms in between episodes. My son is dizzy constantly, worse on standing, heart rate spikes by around 60 to 70 beats per minute. He has a diagnosis of PoTS, but now the consultant is saying this isn't typical PoTS, as he shouldn't be dizzy lying down. Is this a common thing with PoTS, to be dizzy when lying down?
Yeah, that's a nice question. I think, I think that's a good one. I think he certainly sounds like he's got PoTS. And then I'm not surprised. I've had patients as well who've been dizzy when their blood pressure and heart rate have been okay. And so I think that could be an example of where you've got some functional symptoms as well as the symptoms due to the high heart rate and drop in, or threatening to drop of blood pressure. It's not clear to me how all the symptoms arise, to be honest. So because I'm not clear, I wouldn't say, oh, it can't be this, because I don't think we really understand how the symptoms all arise in PoTS. But we do know there's a target in physiological terms to try and help, which is to sort it out so that there's enough blood volume and enough blood pressure, and maybe put a lid on the excessive tachycardia and help muscle pumping and all those other things. But people's physiology is all, is different, just as the way people look is different. And sometimes we can't put it right, and then it's just a matter of trying to live with a chronic disorder that's really incapacitating and try not to let it get in charge of everything, which is hard when you can't get out of bed, But I think the drinking a lot of fluid in the morning helps. That puts up your blood pressure a bit in the morning, so that, that's a good strategy. Compression stockings, all those other things are certainly worth trying, and trying all together. You don't have to just go with one thing.
Okay, brilliant, thank you. I have vasovagal syncope and PoTS, and I often faint without warning when I stand up or when I'm walking. Can you explain why I don't get a warning, and if there is anything I can do to get a warning during these times? Often facial and head injuries occur as a result.
Yeah, no, that's a good question. So you're right, some people get a warning, but some people don't. And one's type of syncope where you don't get a warning is when the heart just stops suddenly, like that diagram I showed you, the EEG. So that'll happen if your syncope is predominantly vagal, vasovagal, but mainly the vagus nerve slowing the heart rate down. That also happens if you have a cardiac arrhythmia. So it's important to get an ECG, measure the QT interval, get that looked at, perhaps even an exercise ECG in those who can tolerate some exercise. So you want to make sure that we're not missing an arrhythmia, which would be treatable and could be dangerous. But it's possible that your syncope is predominantly bradycardic rather than a drop in the tightness of the blood vessels. And unfortunately, there often isn't a warning for those ones. Tightening up the blood vessels using midodrine wouldn't help with that, but there are other treatments that would help if that was the case. So it would be, I'd be curious to know what your ECG, your heart trace, does during your syncope. If there's a stop in the heartbeat completely, as in the ones I showed, for 10, 20, 30 seconds, sometimes longer in adults, up to a minute, I think is the longest in an adult. Strangely, it's not dangerous. It doesn't cause any damage out your heart stopping for up to a minute. And I've had plenty of patients who've survived that and done really well. So I'd be curious to know that, because that might then inform other treatment options.
Okay, that's really helpful, thank you. Does midodrine raise your heart rate?
Yeah, does it raise your heart rate? It's not supposed to raise your heart rate. So it squeezes the blood vessels. I don't think it's supposed to. I don't know from experience whether it does a bit or not. I would have thought not, but I might be wrong there.
Okay, I mean, I can always ask some of our other team members and see if we can pop anything onto Facebook about that. You mentioned about how useful compression can be for some people. I think something that we get asked a lot is where to source them from. This person said, we've been unable to source the tights type, only knee high, which didn't help at all. Is there anywhere you personally recommend that they get them from, or anywhere that you send your patients?
Oh, no, I've had this problem before, and I've just left it with my patients, unfortunately. I think I did have somebody who found a good place, but I can't remember where it was now. I think, yeah, I don't know. Do you know? There would be a good one for PoTS UK too.
Yeah, we've actually, we're just in the process of updating just at the very start of updating our compression page, because it's one of our more out of date pages. So we're just in the process of doing that now. But there are quite a few links on that page. If you go into management of PoTS section, there's a page on compression. So there's a few links there to try to different places. And if you search on our Facebook page for compression, it is a question that's been asked before, and we had lots of responses. So that might be a useful thing to do. I can see he's asked the question, so I'll try and send you the link for that post, so in case that's helpful. Right, we've got time for a couple more. I haven't been asking them in order. Oh, somebody said, could we please see the ANS slide that you skipped? Because it's always good to know the detail. I don't know. Are you happy for me to share the slides with the people who attended afterwards?
Yeah.
Is that okay?
Yeah. Shall I share the screen again?
Yeah, that'd be great. I'll have a look at the questions while you're doing that.
Oh, where's it gone? So, oh, I missed it. Oh, I think it's coming up. It was that one, wasn't it? Can you see that?
Yeah, if you click resume slideshow, I think that will, or click from current slide, I think it opens it up bigger.
That one.
That's the one.
Oh, where's it gone now? Well, I'll go back up. Hang on. That one. Yeah, so there's two basic systems, which I didn't go into this detail. Here we've got the sympathetic nervous system. So that originates in the brain, but the signals come through the spinal cord and then out at these levels of the spinal cord C8 to L2, and they form a chain alongside the inside of the chest and abdomen, called the sympathetic chain. This is one of the bumps on it called ganglia. They're kind of relay stations. And the sympathetic nervous system tends to prepare you for fighting and running away, that sort of thing. So fast heart rate, high blood pressure, dilated pupils, dry mouth, sweating, muscle blood flow is increased. And this other one here, parasympathetic nervous system, again, starts in the brain, but it comes out through these individual nerves called cranial nerves. This constricts the pupil, and then you've got them to the salivary glands. And then this one here, the vagus nerve, goes to the heart. So it tends to slow the heart down, goes to all these other organs as well in your body. And there are a few parasympathetic ones down here at the lower end, which can go to the genitalia, the bladder, and parts of the bowel to try and regulate their function. So interestingly, the parasympathetic can be slowing the heart. So if you have more parasympathetic flow, the heart will slow. If you have less parasympathetic flow, the heart will speed up a bit. And the sympathetic speeds the heart. So if you have more sympathetic, heart rate goes up. If you have less sympathetic, the heart rate will go down a bit. So it's a very complicated system. It's not surprising that it sometimes goes a bit awry and goes wrong, is it? Because the whole thing's quite complicated and varies from second to second, really. You know, what's happening in those sympathetic and parasympathetic nerves.
Yeah, absolutely. Not straightforward at all. Okay, thank you for that. Somebody's asked, would an implantable loop recorder tell me if my heart pauses during my faints? Because I have that.
Yeah.
It would. Okay.
Yeah, that's a good one. Yeah.
Is it normal with vasovagal to shiver and be jittery after a faint?
Yeah, that's not unusual. I think that would be expected. Yeah.
Okay. What is the type of syncope it's called when you faint after peeing? I faint after going to the toilet when I stand up. Yeah.
So sometimes called micturition syncope, in other words, peeing syncope. So several things happen when you wee. Is that a man or a woman? There's a kind of difference there.
I don't know. It's an anonymous.
Oh, so if you have a prostate and you're getting older, then you could get a buildup of pressure when you pee, or you have to push really hard to pee, and that tends to reduce the venous return. So that tends to push the venous blood away from the chest. So that reduces your cardiac output. And then when you stand up, that just aggravates it all, because you need more blood flow and more blood pressure when you stand up than when you're sitting down or lying down. So
the person's just said that she's a 16-year-old girl.
Oh, right. Okay. So you don't have a prostate, but I think that's what's happening is you've got orthostatic hypotension, I would think.
Okay. Well, I think we're going to need to stop there. We have had some questions that I think hopefully PoTS UK will be able to pick up and answer, and if not, we can get in touch again, hopefully with you, Dr. Whitehouse. But I really can't thank you enough. I think it's been a hugely useful session. It will be added to our YouTube channel, so again, hopefully people will be able to benefit who weren't able to make the session live. But thank you ever so much for giving up your time, and thank you to everyone who attended and asked such useful questions.
Thanks.
We definitely won't forget the ones that haven't been answered. We will get back to you. And sorry to interrupt you there, Dr. Whitehouse. What were you saying?
No, just thank you. Thank you for your interest, and thanks for letting me have the opportunity to think about and talk about that.
You're very welcome. Thanks, everybody. Take care.
Bye.
Bye.